Sir, in erythroid precursor, the nucleoli are attached with nuclear membrane.
Oh, good. Excellent. So that's again a sort of soft pointer there. It's not absolute, but correctly said. Usually they have elongated nucleoli, and many times it is attached to the nuclear membrane. It just depends on what orientation the section is being cut. But many of these, if well oriented in the way we want to see them, you will see that the transverse elongated nucleus attached to the membrane. If they are cut like this, obviously these nuclei will be seen as a dot. So that's a soft pointer there that they might be erythroids. And then the cytoplasm is more amorphous. Sometimes the genuine myeloid precursors might start showing dots, the later type sort of blast where the granularity appears. Yeah, okay. So we move forward to the next slide. Good. Right. So similar findings there also. So I add up some information. This patient also had continuous fever for some time. There are, of course, cytopenias, and clinically, the bone marrow request form came for to rule out tuberculosis and hematological malignancies, since there was also a little hepatomegaly there. So we had megaloblastic erythropoiesis with marked hypercellularity, and we have already discussed the cell. So this is another patient. You see the red border there. This is a very recent patient, and we still don't have the diagnosis because this patient also has some organomegalies. You see how predominant is the erythroid population. There is some dysplasia also coming up in erythroid series, but around 10% or around that dysplasia might be seen in severe megaloblastosis also. And then there are giant sort of metamyelos coming up. So pure megaloblastosis versus erythroleukemia is still a diagnosis to be made in this patient. Remember, if you get a clinical history, that patient has already been given B12 folate, an adequate supplement, including iron. Sometimes there's dual deficiency and the response might be limited in that scenario. Or even if you say that the oral might not be effective due to a number of causes of sort of vitamin B12 or folate deficiencies, which might affect intestinal absorption. If the clinician tells you that the parenteral sources have also been tried, and including transfusions. Remember, a transfusion, single or maybe two transfusions might be enough. A single transfusion might be enough for a dosage of B12 and folate to show you a response, reversal to a normoblastic picture in some due course. So in that scenario, the likelihood of not being a megaloblastic anemia is there. So that input is very important. And in any case, if you have confusion like this case, which is very recent, you can still give a trial for B12, right? So that's just a picture to show normal, early, intermediate, and late. That clump should be there with hemoglobinization. That's the megaloblast, early megaloblast. The late sort of erythroid cell, which is showing opened up sieve-like chromatin, and the hemoglobinization is adequate. So that is how the megaloblast will look like. If this megaloblast is severe, you stop seeing the late forms, and there's a rest of maturation. You start seeing the earlier forms more often in the bone marrow. Okay, so those are the usual findings in peripheral blood. That's just theory. You can read it off: macrocytosis, oval macrocytes, teardrops, segmentation, hypersegmentation, and some other findings. Bone marrow, of course, hypercellular, erythroid hyperplasia, megaloblastosis, some amount of dyserythropoiesis might come off, giant metamyelos, band forms, increased histiocytes because of cell death, ineffective hematopoiesis. So again, theory, B12, folate, there might be causes of food, stomach, intestine, drugs, and various causes. So, I mean, we can go through that, but that's not the purpose. We are more towards how to differentiate between one thing or the other. Folate, again, there might be nutritional causes, malabsorption, some drugs, some growth stages, infancy, pregnancy, malignancies where absorption, utilization of folate is very fast, tropical screw, gluten sensitivity, some drugs which cause folate deficiencies, and there are rare causes like, say, thiamine sensitive, responsive sort of megaloblastic anemia, and some other rare causes. So I stop here. We in our practice, when we see a cytopenia with erythroid hyperplasia with megaloblastosis, maybe minimal or mild to moderate or severe even, there are diagnoses which can trouble you as pathologist. MDS needs to be ruled out. Erythroleukemias might become a diagnosis. We have seen misdiagnosis of hematosplenic gamma deltas, which present as hypercellular marrows, erythroid hyperplasia, some amount of megaloblastosis. They get diagnosed as megaloblastosis, and or ITPs because there's thrombocytopenia, some hematomegaly, splenomegaly, and the odd sort of diagnosis which come into picture, and it becomes troublesome to report megaloblastosis per se, because usually the patient come with some sort of treatment, right? So yeah, so let Rishi come in at this stage, his perspective with uh, clinical picture in this case, or clinical issues.
This is a it appears very straightforward, but it is a very tricky diagnosis for a hematopathologist as well. And if you just do a PubMed search, you may find some old papers saying that these patients have even been evaluated and undergone a bone marrow transplant as well, because they got misdiagnosed as myelodysplastic neoplasm. So many times in the clinic, I also tell the patient, if they have a mild to moderate anemia, not yet requiring transfusion, some macrocytosis in the smear, so take a trial of injectable B12 and come back and see me after 2 weeks. By the time we give an appointment for a bone marrow examination and other things, and occasionally they come back after 2 to 3 weeks that we have undergone a marrow examination, but now our complete blood count is completely fine. So this happens not uncommonly. Having said that, always evaluate the patient as per the again, clinical history is important. One clue is that LDH is not elevated in thousands in MDS, and neither is it elevated in thousands in acute myeloid leukemia. So LDH is elevated in thousands in PNH. It is elevated in thousands in other causes of intravascular hemolysis, and it is elevated in thousands in megaloblastic anemia. So if you see a elevated LDH, then with elevated MCV in the peripheral smear, with a preserved neutrophil and lymphocyte ratio. Remember that if you look at the aplastic anemia CBC, both megaloblastic anemia and pancytopenia will have both aplastic anemia and megaloblastic anemia will have pancytopenia. Look at the proportion of neutrophils and lymphocytes in the differential. If neutrophils are low, lymphocytes are high, the possibility of aplastic anemia increases. The possibility of LDH is elevated, aplastic anemia with concomitant hemolysis like PNH, differential should be entertained. However, if the neutrophils are predominant and lymphocytes are less, as happens in a normal person's differential blood count with elevated MCV, with elevated LDH, with a sallow complexion, mildly palpable spleen, and no other mild jaundice on physical examination, some elevation in unconjugated bilirubin, possibility of megaloblastic anemia becomes even stronger. In that situation, look at the marrow. If you have a clear-cut diagnosis of megaloblastic anemia, fine. If you have some doubt, then obviously evaluate as per hematopathology algorithm. But these are some clinical clues, and there are a lot of causes for megaloblastic anemia. Diabetic patients who are on metformin, patients who are on protracted proton pump inhibitor course, proton pump inhibitor abuse, omeprazole, pantoprazole, and all those drugs. These are causes that are commonly responsible for megaloblastic anemia seen in the era of modern medicine. Then we don't often find pure vegans in the society much. Almost everyone has milk, cheese, which are rich source of vitamin B12. Then pregnancy is another cause for megaloblastic crisis. Pregnancy, megaloblastic crisis. Obviously, some theory that B12 deficiency takes years to develop, folic acid deficiency develops in weeks. So, and both are important causes for megaloblastic anemia. So these are some of the my clinical opinions from my day-to-day clinic. That is how I practice. In my how I look at the megaloblastic anemia patients in my practice.
Right. Thank you, Dr. Rishi. If there are questions, I think, Dr. Kanchan, we can take this one.
Sir, this is Dr. Priya here. So there are two
Okay.
questions. What size should be giant metamyelocyte?
That's a difficult question, but usually you compare with promyelocytes as a large cell. But I don't have a correct reference to that. So that is the size I look for in my experience for a giant metamyelocyte.
Okay, so one more question. Can myeloid maturation be markedly suppressed in megaloblastic anemia?
Yes, it can be. Sometimes you see rather erythroid series might not be affected to that extent, rather the myeloid series might be affected to a large extent, and you might see a maturation arrest at myelocyte or a promyelocyte stage, also in severe megaloblastic anemia. So, the lineage, remember megaloblastosis is a systemic disorder. Any cell which is proliferating in body, it will be affected. So you see, sometimes people diagnose megaloblastosis in pap smears because of megaloblastic changes in the nucleus. So it's myeloid lineage is always affected. The extent it depends is sort of individual to individual. So sometimes the erythroid series might not be affected to that extent, whereas the myeloid series might be affected more.
Okay, so there is a case scenario. Dr. Mithu Mohanty has put it in the chat box. 65-year-old male underwent surgery on spine and within 3 months he had pancytopenia. What could be the cause? During OT, he had low platelets.
65-year-old male with
Underwent
pancytopenia.
surgery on spine and within 3 months he had pancytopenia.
Okay, so that's a real life question to be answered, and you need to obviously look into right from the basic investigations and basic clinical examination. So you need to have more inputs. That is there some organomegaly, lymph nodes coming up? It could be anything malignant to non-malignant conditions. Basic investigations to say how much is the cytopenias, any sort of autoimmune disorders, so that part of workup. Yeah, so it's a broad, it's actually the algorithm you are looking into for pancytopenias. Dr. Rishi, if you can.
It needs evaluation.
Right.
Patient has a orthopedic surgery and in 3 months has pancytopenia, then the evaluation needs to start from what were his blood counts at the time of surgery. Did the surgery happen when he was already having a problem that was in evolution and now has manifested fully, versus he was completely normal at the time of surgery and now has a problem? Then the approach of diagnosis, differential, it differs, right? Something that has started. So if you look at the old blood counts and say, okay, he had some mild thrombocytopenia, not 150,000 platelets, but for instance, platelets of 100,000, some elevated mean corpuscular volume, a hemoglobin of not 12 or 13, but somewhere around 10 to 11. And now the thing has evolved a bit, so the pancytopenia has progressed. So then the differential will be different. And if it's completely normal and now pancytopenia is there, then the differential is different. In the first scenario, I would think of if the elderly gentleman myelodysplastic neoplasm or aplastic anemia in evolution, versus now if something has happened catastrophically over a period of weeks, then megaloblastic crisis, or some drugs that have been given, linezolid, which is given for more than 3 weeks, leads to cytopenia, pancytopenia. So very broad-based net we have to cast on the basis of information that has been given. But I am just giving you an idea of how to approach these patients, and possibly the person who has asked the question may be able to find out. Then somebody has asked a question, what is the recent WHO cutoff values to say pancytopenia? So WHO does not give a cutoff value for pancytopenia to the best of my knowledge. It is International Aplastic Anemia and Agranulocytosis Group that gives the cutoff of pancytopenia, where it is defined as hemoglobin of less than 11, white neutrophil count of less than 1500, and platelet count of less than 150,000. However, for seriously considering diagnosis of aplastic anemia, the neutrophil count in practice is taken as less than 1000. Platelet cutoff is taken in practice as less than 100,000. And hemoglobin in practice is taken as less than 10 gram per deciliter.
Right. Thank you, Dr. Rishi. So can we move to the next?
Yes, sir.
Case?
Thank you, sir.
Right. Good. Thank you. So nice questions coming up actually. Good. So case 3, and so I ask Tanushri, Paul, can you come in? Is your system okay? Right.
Yes,
So
sir.
let's see. So this is 36-year-old male, case of chronic kidney disease, post-renal transplant, and patient was on triple immunosuppression. And the patient presented with fever for 2 months and worsening cytopenias. On examination, patient was febrile and had pallor. Again, there is anemia and there is marked sort of leukopenia with only 800 count and platelet of 82,000. So let's go to the smear at the LOPAR, peripheral smear at the LOPAR. So any comments at LOPAR you would like to make?
The screen is not visible yet. Yes, sir. Now I can see.
Okay.
Sir, there is leukopenia. WBC count is reduced.
Right.
RBC, I can see normocytic.
Okay, you want
More
to
or
comment
less.
on morphology on this part? That's okay. I think it's just the lower density of RBCs again. We can possibly go on the morphology in the next slide. So here I think you can comment on RBC morphology. Yes, Dr.
The
Tanushri.
slide is not visible yet. Yes, sir. Can see.
Okay.
Yes, sir.
Okay.
Can see. Sir, yes. Normocytic. There is some acanthocyte, some white cells.
Okay.
Few cells are microcytes are also there. Then hypochromasia, sir, is not prominent. But few cells show hypochromasia. I see one neutrophil
Okay.
and while few platelets are also seen.
Okay, so platelets is better not to comment because this is actually a finger prick smear, where the platelets might be pseudo low at times. Your findings are mostly correct. I believe that the size variation among RBCs is there, but it's mild. Probably some smaller and maybe some larger. Most of these are normocytic. Probably most of these are also normochromic. You see a central pallor, which is just occupying, in most of these occupying a little 1/3 of the RBC. There are some poikilocytes, mostly crenated forms. I don't know whether it's a true bite cell or not, but yes, there are some poikilocytes there. Right, so we move to the next. And what cell do you see here in the center? Any idea?
Sir, I think this is degenerated cell,
Okay,
WBC.
so this is a myelocyte.
Degenerated WBC.
No, this is a myelocyte.
Degenerated.
It's a
Yes,
myelocyte,
sir.
and which means there
Okay,
is
sir.
sort of no problem. Yeah, so it's a myelocyte, which means there are sort of immature
Sir,
cells in
here.
the circulation. And what cell is this?
Okay, sir. Sir, target cell.
I'm pointing to the cell.
Okay.
It has a
Nucleated
nucleus.
RBC.
Yes, it's
Nucleated
nucleated
RBC.
RBC. So you see that there are circulating nucleated RBCs and they are circulating myelocytes in the peripheral blood, which has a very low count. So a low TLC with a leukoerythroblastic picture, right? Anemia and thrombus. So here that's the sort of EDTA sample there, which shows some platelets and they are also reduced.
Yes, sir.
Yeah. Okay. So with that, so that's the count. You see some neutrophils, lymphocytes in equal proportions. You do see the circulating myelocytes, metamyelocytes, and an occasional circulating NRBC in this. Just to summarize the picture, so there is a leukoerythroblastic picture in this patient. We move to the bone marrow aspirate because if you go into differentials of leukoerythroblastic picture as leukopenia, at this stage there again will be a lot of causes, malignant as well as non-malignant. So let's see if Tarun Jyoti can come in here.
Yeah, so it looks like
At LOPA, you want to comment anything at this stage? The patient is 60 odd years.
the marrow looks cellular.
Okay, right. So it's probably normocellular, the aspirate, although aspirate is not the best way. Refined biopsy is the best way because, yeah, it can have other alterations. Right. So this is possibly somewhat cellular marrow if you don't want to categorize as normo versus whatever. We also see some other cells at this high, this power.
The megakaryocytes can be
Right.
shown
So you
as-
see some megakaryocytes also. I think that is enough at low power. We can go to the next parts just to highlight the megakaryocytes that they are abundant. They are normal, adequate in this aspirate. So we can go to the next part for morphology. So what kind of cells you see? These cells,
They are myeloid cells.
these ones, is hemoglobinized cytoplasm. You can match that.
Yes, sir. These are the late normoblasts.
Okay, so these are late normoblasts. Those are the early normoblasts. So right. So you identify because of their cytoplasm there, which is hemoglobinized as late normoblast, a clumped chromatin there. And of course, they are myeloid series of cells. Adequate. So you see erythroid cells, myeloid cells, megakaryocytes. Basically, the marrow is cellular and shows the important series of cells. Again, you see some more cells. What are these cells? Yeah, Tarun Jyoti. Eccentric, Golgi zone, blue cytoplasm, eccentric nucleus.
Plasma cells. Sir.
Yes, so you see some plasma cells coming up here in this smear. There are again a lot of myeloid cells. There is possibly another observation that there are a lot of myelocytes, promyelocytes, but the maturing neutrophils are less. In the previous smear also, they were low in numbers, and in this smear also, they are low in numbers. So maturing neutrophils probably are less, and you see some plasma cells. Okay, so what's that cell? Fuzzy borders. It's some sort of cytoplasmic.
This could be macrophage.
Yes, so that's the macrophage. So you see, there are normal hematopoietic cells and there are some plasma cells. I'm tending to show you some histiocytes. So basically, what I'm representing here is there is some reaction in the marrow. If you also observe some cells show a sort of a stronger granulation, a little coarser, little prominent granulation. So overall, the marrow is reacting to something with presence of plasma cells, histiocytes, right? And that's the differential for you. So there are enough sort of granulocytic precursors, 24 myelocytes in neutrophils, which should be around 1/4 to 1/3 of the cell population in a bone marrow. It's slightly on the lower side. Lymphocytes are just sort of okay, but plasma cells less than percent are okay, but they were prominent in some places. So in counts, they are just 4%. Erythroids are just normal there. So that's the differential, and we go to the biopsy. And again, Tarun Jyoti. So what do you see at this low par?
Looks like I could say normal to hypocellular.
Okay, sorry, I said 60 years. There's a 36-year-old young lady, and obviously this is hypocellular refined biopsy. So you see, there was probably some discorrelation there. You might have aspirated from a little more cellular area, and overall the trifine is showing quite hypocellular areas there. It's probably around 70-80% of fat spaces and just around 20%, 10-20% of cellular spaces. Anything else to appreciate? A sum of nodular looking or rounded area there, which is different from all this marrow spaces. Okay, slightly higher par again. You see that marrow is looking hypocellular. At times you might comment. That's I'm telling you for exam purpose also. Do not forget all the components of refined biopsy. You might comment at the trabecular. They are normally thickened. They are not very sort of thin or thick. There is no osteoblastic activity, rimming, paratrabecular fibrosis or paratrabecular other things are not seen. So these are comments you need to make in a usual refined biopsy, probably at this par also. There's another sort of a nodular aggregate collection coming here. At higher par, what do you see? Can you describe this? Try and attempt and describe what is.
It's probably a sinusoidal space surrounding that. Mostly adipose tissue is there.
Okay.
Thick fibrosis.
Okay. So, okay. Anybody else? Priyadarshini, Dr. Priyadarshini, can you come in?
AJ clusters of foamy cells.
Okay. Clusters of foamy cells, somewhat vacuolated appearing.
Vacuolated appearing.
Okay. So, probably Taranjyoti is interpreting these as adipocytic cells. You know, most of the adipocytes are mostly larger till the time they become atrophic and rounded off. Then you see a mucinous change, a gelatinous transformation at that time when the fat atrophy occurs. The cells become very small, rounded off, some pink material also. So this is a nodular collection of histiocytes, correct? And most of these are quite vacuolated. Right. So at higher power, anything else we appreciate in this collection of histiocytes? I'll point out to something there. So why should histiocyte or a sort of, it's not looking like an epithelioid granuloma, it's looking large vacuolated histiocytes. You see some scattered nuclei there, but mostly it's all cytoplasm, very expanded and vacuolated. So something there in the vacuoles. Any comments what it could be?
Sir, is it fungus? Any fungus?
Okay, good, excellent. So we see fungal profiles, and what profiles? Yeast forms mostly. है ना? So fungus can occur in hyphal forms and fungus can occur in yeast forms.
Capsulate.
So if you start from the history of the patient, the patient has been transplanted, is on immunosuppression, has fever for 2 months, has some sort of organomegaly, you are looking into with cytopenias, you're looking into a frank infection, it could be many. And this morphology represents with histocytic collections, vacuolation, and some odd organism which is not very well staining. You see, some of these are very faint yeast forms, and some of them is probably vacuolated. So what next could you do?
So past stain or
Okay, good. So PS stain. So why do you want PS stain? What are you looking into? What organisms?
Cryptococcus, histoplasma, maybe.
Okay, good. So if I show you PS at this moment, these slides were not given to you. The nodule with PS staining,
Positive.
yeast forms, right? Rounded forms. Some of them are budding, narrow budding there, right? Budding there. On higher power, you see these vacuoles are containing PS positive organisms. Variable size, some of them are really large. You know, they are not like, some of them might be 2-3 microns, but they are really large, 10 microns.
10
As good
microns.
as some lymphocytes or something there. Yeah. And anything else which you can do? So PS positive could be cryptococcus, could be histoplasma also.
So
The
silver
clear
stain
looking
or
capsule is not stained.
Capsule, PS will not stain capsule. So what will stain capsule?
so silver methamine stain.
GMS.
Okay, methamine stain, very
GMS.
nice.
Gomorrhea.
Right, GMM, Gomori methamine stain. Nice. Anything else? Tarun Jyoti, any other stain?
India ink.
India ink
Capsule
is
in
not
it.
used in section. Where it is used? It's a negative stain. If you
Culture.
not, sorry.
In culture, basically.
Okay, maybe in diagnostic scenarios, India ink is used in CSF. You know, when there is a sort of cryptococcal meningitis or yeah. So there, the India ink probably is the fastest stain. Get CSF sample stain with India ink. You see negative shadows. That's Elchin blue for you. So Elchin blue will stain the capsule. It's rather a combination of PS and Elchin blue. And you see nice rim of capsule of cryptococcus and a faintly staining body there of PS, right? Some of them are good staining. Most of them are faint here in a combination of PS and Elchin blue. And that's how the cryptococcus will look like. Right, so that's for a diagnosis of fungus. And in this scenario, you might find also granulomas. There's another patient, post sort of bone marrow transplant. I don't remember years, but this is probably more than a year later. And you see granulomas, epithelioid cells, and that's another infection we need to look for. There can be other kinds of infection and you need to identify organisms which can look like fungus at times. So that is one. Anybody, which is this organism? May not be related to immunosuppression state. Sorry?
LD bodies or
LD
LD
body, right? So you see the double dot appearance with a kinetoplast, है ना? A very close DDC is histoplasma, which does not have a double dot. Similar size, intracellular organism again. So if you have a double dot, it is an LD body. So cytopenias in case of leishmania, the most common cause. Anyone again? What would be the cause of cytopenias in patient of leishmaniasis? No, hypersplenism. The most common cause is last spleen. It will give you cytopenias, but it might be that sometimes HLH come into picture. So those are rare findings which might come. Okay, so in this scenario, when the patient is post-transplant, this is renal transplant, you might see patients with other transplants also with cytopenia. So that becomes at some stage of treatment, patient still under immunosuppression, you know, there might be series of causes. So I ask, there might be so much of causes, but if there's fever, you obviously look into infections. But I asked Dr. Rishi to come in a scenario of a transplant, maybe a bone marrow transplant or whatever is sort of clinical viewpoint is.
Usually, these patients, if they present with acute febrile illness with mild to moderate cytopenias, then we ask for a bone marrow examination. For febrile illness, we do the imaging of the chest, and we look for other clinical localizing causes. So, you know, infectious fever is always has a sudden onset, high grade, and there is a clinical localization. So when we suspect an infectious fever and cytopenias, we always evaluate for the cause of fever, and then the bone marrow examination throws up these findings. So these are all spot diagnostic observations in the marrow. And if you see a bug, you see a bug.
Yeah, true. So yeah, just need to learn to identify these things and suspect. Sometimes this was quite obvious as nodular collections, but sometimes they can be very subtle. And in our scenario, remember, if the patient is on immunosuppression, sufficient immunosuppression in this scenario, maybe an HIV presenting or other high dose steroids being going on, multiple immunosuppression going. This scenario, I would like to rather do special stains, even if I don't see too much of reactions and changes. A subtle sort of reaction is good enough to do an AFB stain, a PS stain, and you might be surprised to catch one odd organism without much reactions in immunosuppression patients. So remember to, in this scenario, when the patient has fever and immunosuppression, even without such morphological clues which may not be apparent, you go for these stains and you might land up catching. We not very often, but rarely we do see these organisms even without much changes in marrow.
These are all disseminated infections. So please remember, you will find these patients in immunosuppressed patients predominantly. Immunocompetent patients, we will not find these kind of disseminated infections of Cryptococcus, histoplasmosis. So especially Cryptococcus, HIV, renal transplant, bone marrow transplant. These are the patients whom you will find this disseminated cryptococcosis. And usually they are the ones who will have a lung infiltrate as opposed to, CNS infiltrate. CNS involvement of cryptococcus is also common, but there the bone marrow involvement is less likely as compared to the ones who are having pulmonary cryptococcosis. Skin lesions, rarely skeletal lesions for cryptococcus. So keep in mind the clinical scenario. Always make your pathological diagnosis on the background of clinical scenario. You are not magicians who are expected to pull out rabbit from the hat. Always stress for clinical scenario, and then try to place your pathological observations in the background of clinical scenario. That is very important. Please don't disregard that. Always stress for complete information to be given to you.
Right, that's exactly true. Rather, hematopathology cannot be practiced. It's just a scenario cytopenia till the time you have some clinical input. You need your directions to move to next investigations. What you look for, you need some clinical inputs for that. Otherwise, you are just going in blind and trying to pick up things. You might end up picking up something at given case, but the best way is to get good clinical information and start looking for what is expected in that scenario. Any questions on this at this time?
Yes, sir. We have two questions. The first one is, when we do bone marrow cell count, should we express as percentage of all nucleated cells or percentage of WBC series only?
So no doubt about the practice conventional guidelines, all nucleated cells. That is the convention. It includes all kinds of nucleated cells, none left, right, in your aspirate when you give the count. So don't exclude your the erythroid series of cells. Don't exclude your plasma cells or some histiocytes. If they are there in your count. So the bottom line is all nucleated viable cells you are seeing on your microscope. Done. So some people they might be practicing some odd things, but that's fine. You can do it. But the convention is all nucleated cells. Otherwise, you might be diagnosing if you're not in the same page, you might not diagnose AML as AML, or you might diagnose more AMLs because your denominator is different. You're just counting myeloid cells and giving blast count out of the myeloid cells. Don't do that. It's all nucleated cell. Yeah.
And the next question is, occasional normoblast and neutrophils with shift to left. Can we say leukoerythroblastic blood picture?
Yeah, you still say that because it is still leukoerythroblastic picture, the immature cells. The term does not designate a high count or a low count in itself. Generally, it's traditionally it is associated with a higher count with a lot of cells, but you see these immature cells in a low count also. It's still a leukoerythroblastic picture.
Yes, sir. We don't have any more questions at this stage.
Okay, so I think we move to the last case there. So I call up Dr. Raina again for this case. We start. So this is a 61-year-old female. Patient had dengue infection a few days back and resolved, but presented with septic encephalopathy. On examination, the patient had generalized swelling and bed sores, so was in bad shape clinically. CECT examination did not reveal any organomegalies, lymph nodes there, or any gross abnormality. Patient was started on anti-tubercular therapy and steroids just 3 days before the marrow was done, and the patient still had worsening cytopenias. So there's anemia, there is there is leukopenia, and there is thrombocytopenia in this patient again. And we look into the peripheral blood film and low power. Dr. Anna, anything you would like to comment again?
Low power RBC density is low, as well as total leukocyte count is less. Platelets can be appreciated at this
Right.
part.
So I think the RBC count low, anemia, and low TLC is the picture there. Remember, at this part also there are many negative things which you might say. So in case of a monoclonal gammopathy, there is a background, there are clumping of cells, rouleau formations. In carcinocythemia, there are clumps of cells. So very high TLC might indicate something. There might be odd other things, parasites like microvilli. So these are things which are negative findings, which you appreciate on low power also, right? Done. So none of those, but the basic finding is a low density of RBCs and leukopenia. So at higher power.
Manu, we can't see you. Your video is off. Manu?
Yes, I personally
Okay.
purposely did it,
Fine,
but I
fine.
can again start it. Yeah. Okay.
Sorry.
So am I looking good? Right.
As handsome as always.
Oh, thank you, sir. So yes, please. So Rena, please.
Sir, in RBC series, mild anisocytosis as well as poikilocytosis. NRBC is a late normoplasticity.
Right. So there is circulating NRBC there. RBC picture, you are probably correct. There is a size variation. There are normocytes, there are some microcytes, maybe some macrocytes also there. So I'll put it as mild anisocytosis. Poikilocytosis is minimal probably. I don't know. There's a fragmented RBC seen occasional or maybe an artifact. Poikilocytes are minimal. So I'll put it as a mild anisocytosis with presence of circulating NRBC. Right. That's band form. Yeah. Again, a cell in the center. Possibly a myelocyte. Yeah, possibly. We move forward. Again, you see something about the neutrophils. There's odd looking neutrophil probably. Maybe that was also a neutrophil. So odd looking neutrophil. There's something odd about these. Can you catch the cytoplasm?
Vacuolated form.
Sir,
Vacuolated cytoplasm.
vacuoles.
Right. So in
Yes.
most of these pictures, they were showing vacuoles. Right. In the first pic also, there were some vacuoles. The granulations probably are not that prominent, but they don't look really good. Not the nice looking of a nice knife non-reactive neutrophil. They're looking something bad about the neutrophil there on morphology. Okay, so here you do see some poikilocytes coming up. Done. So that's the sort of differentials, and you see the myelocytes there and NRBC. So again, there is a leukoerythroblastic picture, but still low counts, right? And it's sort of toxic changes. The granulations might not be too coarse or dense, but there's some reaction in the granulocytes. What else you could see in toxic granulose neutrophil? There could be vacuolations, there could be coarse granulations. Anything else? Some bodies?
Dole body.
Dole bodies, exactly. Dole bodies. They are usually a pale basophilic body, usually at the periphery of the neutrophil, maybe seen anywhere else also in the cytoplasm, and usually one in a neutrophil. Okay, I don't have the pick. Bone marrow aspirate. So who comes in? Like Tanushri Purohit come in for aspirate. So at low par, any comments in 61-year-old?
Sir, probably a normal cellular marrow can be seen, and the trail looks moderately cellular. And
Okay, so yeah, I'll accept that. It's probably a normal cellular looking marrow. The trails also show some cells there. I don't see a megakaryocyte as yet. But yes, so you see them here.
yes, sir.
So enough megakaryocytes for you.
Megakaryocytes. Yes, sir.
Right. So we move to the next part for morphology. What all cells, what all lineages, and what all cells you see?
So I would say this myeloid cells plus the erythroid, the late normoblast nucleated RBCs are also seen.
Exactly. So you see nice, yeah, erythroid precursors which are late, sort of erythroblasts, and
Yes,
you
sir.
see myeloid series of
Myeloid
cells.
series, sir. Yes, sir.
Right. You see some mature cells and some immature. Done. Okay. Anything else to comment in this?
So histiocytes, I could say in macrophages, engulfing RBCs.
Okay, good. Again, probably the same, है ना?
Yes,
Rather,
sir.
this one, yeah, this photograph was not given to you. This one is, I would say, rather trying to capture this cell.
Capped. Yes.
Yeah, okay. So on Hyapar, rightly described, there are RBCs inside the cytoplasm. They are sort of very angry looking, large, P2, yeah, swelled up macrophages, histiocytes, and
Yes,
trying
sir.
to eat up cells. Rather, they're trying to eat up, both of these are trying to eat up this one also. Yeah, trying to knit up a story there. And some debris also. Yeah, vacuolated, they're angry looking, they are activated, they're engulfing cells. And more of these. So you see nucleated cells now in the cytoplasm. That's probably these macrophage nucleus cells.
Macrophages.
Yes, the bubbly and lot of cytoplasm. And if you see a normal looking histiocyte of a bone marrow, it is usually has dendrites, is a slender cell, have projections all over. Once it becomes active, it starts swelling. The cytoplasm becomes increasing, vacuolated, and this one is eating up
Eating up.
a lot of cells. Again, yeah. So you see a lot of these cells. You see some plasma cells, erythroid cells, neutrophils. So the marrow basically shows a lot of histiocytes which
Histiocytes.
are eating up cells. So
Yes, sir.
basically you have presence of
Hemophagocytosis.
hemophagocytosis.
Yes, sir.
Any comments on this stain? Particle stained, blue particles. What could be it?
Pearl stain.
Pearl stain.
Pearl stain,
Pearl
right. So it
stain.
stains iron. And in this case, anybody can tell me the grading? 3 or 4 plus. So you need to read that grading. I think it could be 4 plus there. a lot of iron in the particles, and these are basically histiocytes storing the iron. You could see occasional histiocyte lying outside because it has been pulled out in the trails. You know, if the iron is loaded in the histiocytes, it could be a good stain to localize histiocytes with hemophagocytosis. You
Yes.
see, identify the histiocyte with Pearl stain and too many nuclei in the cytoplasm. So in a high Pearl, in a high iron content storage iron patient, you could see how many cells it has engulfed. The Pearl stain might help you to identify these histiocytes in the trails, showing hemophagocytosis. That's just a sort of clue there. Refined biopsy, again, Tanushri, 61-year-old patient. Yeah.
The trophine biopsy shows a more to a hypercellular, and they have like pockets, islands of cells, focus of cells are there, but majorly hypocellular marrow, I can say.
Right. So 61-year-old, I think it's probably normal to mildly hypocellular. You might be right if you subtract with age, 40% cellularity is there, but remember it might not go that way. So at this focus, I'll put it probably a normal to mildly hypocellular for 60 years. Okay, mildly hypocellular definitely. Trabeculae look normal. Yeah, so no aggregates of cells here. This cellularity is just okay for 61. It's definitely okay for 60
Yes, sir.
years. No problem for that. And then we go to the cellular areas. Anything here? You see megakaryocytes?
Yes, sir.
Probably you see the granulocytic cells, lot of granulocytic cells, some erythroid islands, the fluffy cells on the, again higher power.
Yes, sir. The macrophage.
Right. So yes, so large amount of abundant cytoplasm, some vacuolations, fuzzy cells, some cells probably inside
the cytoplasm.
Yes. So a lot of RBCs inside probably these histiocytes. So you need to carefully in the refined sections, you might need a careful look there to identify these cells. Some stains can help at times. PS stain, you know, it brings about these vacuolated cytoplasm cells inside these histiocytes. Some fragments, RBCs inside more likely. I might have another stain for you. So that's Mason's trichome actually. This is too red appearing, but sometimes it shows the histiocytes with RBCs prominently inside. So just, yeah, another stain, but PS might be of help.
Yes, sir.
So basically we are dealing with
hemophagocytic lymphohistiocytosis.
Right, so that's theory part. You could always read it. So there are diagnostic criterias, and we have 5 out of 8 which is required, and you can diagnose HLH with your morphology, with a lot of histiocytes. Obviously, you require a clinical scenario and some biochemical parameters. You know, phagocytosis at a minimal level is a part of bone marrow because 90 or maybe more number of cells die regularly. You don't find them in a normal bone marrow easily. You will have to find them out. So once you start seeing them easily under your nose microscope, there probably some increase in phagocytosis. And obviously, if there's a clinical scenario and there's a lot of these histiocytes eating up cells, you are dealing with a pathology. And you know, this is not a diagnosis, this is a condition. Like pancytopenia is not a diagnostic condition, it's a scenario. So HLH, finding an HLH is a scenario you need to get into the etiology, because for management of the patient, you need to hit the etiology, right? So again, the etiologies can be primary or secondary, depending on whether it's genetically associated or it's infection driven, malignancy driven HLH, and you probably treat the patient accordingly. In an acute scenario, you will also like to reduce the amount of phagocytosis by giving some amount of immunosuppression. So let Dr. Rishi talk about a scenario of HLH, cytopenias in HLH, and how we look into the patients, right?
This is a diagnosis that until few years ago, pathologists and clinicians both were not very aware of. Maybe if you look back, maybe say 7 to 10 years ago, patients essentially went undiagnosed in many centers, because this is not as Dr. Manavdev said, hemophagocytosis is not a diagnosis. It is a manifestation, like iron deficiency anemia. It is a manifestation. We have to look at the cause of iron deficiency anemia. In the elderly, rule out those mitotic lesions. In the Similarly, for hemophagocytosis, in the adult patient, remember 3 or 4 broad-based causes. Infection. Commonest is infection. Viruses, EBV, dengue. These are common viruses for hemophagocytosis, which can present with HLH. There are some papers that say that in adults EBV is not very common, as primary EBV infection in adults is rare. So the jury is still out on that. But then second is autoimmune, systemic onset juvenile idiopathic arthritis or adult onset Still's disease. So one of the questions that is frequently asked on the rounds in hematology is, which are the 2 differentials which have the highest ferritin? And the answer is HLH and adult onset Still's disease, where you can see ferritin elevations of more than 10,000. Lupus, SLE, again. When HLH occurs in a background of autoimmune disease, then the manifestation is called as macrophage activation syndrome. So essentially, HLH and MAS are the same in terms of manifestations and other things. However, macrophage activation syndrome occurs on the background of an autoimmune disease like systemic lupus erythematosus or juvenile idiopathic arthritis or adult onset Still's disease. Why the distinction is important? Because MAS or macrophage activation syndrome is exquisitely responsive to steroids, usually. So infections and autoimmune diseases. The third cause is lymphomas. And there are a couple, so there is a whole variety of lymphoma, PNHL, TNHL. However, if you look at the association wise, the association is, PNHLs are more common than TNHL. So that obviously is more associated by the virtue of numbers. But there are some lymphomas that are there where HLH is presentation more often than not, and it is very ominous. So angioimmunoblastic T cell lymphoma, HLH. Aggressive NK cell leukemia. Dr. Manupdesh, am I right? It is NKLGL, aggressive variant of NKLGL. So that is, again.
You were right till 2016. Probably the entity has disappeared in 22, but that's fine. The nature of the disease still exists. Yeah.
Yes. And then I messed up one diagnosis retrospectively. I think that is intravascular large B cell lymphoma, intravascular DLBCL. Very, very tricky diagnosis, but yes, presents with HLH. And intravascular DLBCL, because it is intravascular, you have to have a high index of suspicion. And, I mean, I'm just enumerating these scenarios so that when you get a patient of HLH, look for infections. In fact, visceral leishmaniasis can present with HLH. Then look viruses, ask for EBV DNA PCR, and look for autoimmune diseases on a background, look for dengue serology, and in an adult patient always have a high index of suspicion for lymphoma. Always. And if you look at the manifestations of the commonest lymphoma like follicular or diffuse large B cell lymphoma, HLH will not come at the top. But then there are some lymphomas which often present with HLH. T cell NHLs, especially angioimmunoblastic T cell lymphoma, intravascular B cell lymphoma. So when we get a call for from the internal medicine that here is a patient who has pancytopenia, who has fever, who has acute presentation, and sudden precipitous drop in blood counts synchronous with fever and has a palpable spleen, I always say, okay, get the ferritin done. Ferritin is elevated. The criteria says more than 500 nanograms per milliliter, but often it is elevated in thousands. Then, okay, do a marrow. And remember, from a clinician's perspective, HLH will, occasionally be missed on bone marrow examination or a CSF examination in patient who has neurological manifestations. It is when the disease is often, very progressive and advanced that we get bone marrow evidence for HLH. The reason being that this is probably the reason why, if you look at the literature of HLH on the bone marrow in various patients of HLH series, they say 0 to 90%. So broad range for getting bone marrow evidence for tissue examination evidence for HLH. So the diagnosis is often made clinical rather than pathological. So that is another thing to be kept in mind. And depending on the cause, it is prognostic. And I always ask for a PET CT also, positron emission tomography CT scan, PET CT scan. Why? Because lymphoma is one of the common causes for adult HLH. I always ask for a PET CT. And so in that, and if you are considering lymphoma, always do a PET scan and try to obtain a tissue for diagnosis of lymphoma if you see lymph node. Tuberculosis is another common cause for HLH. One of the recent, a year ago, one of the sons of a prominent minister in the central government got admitted with HLH with tuberculosis and responded to anti-tubercular treatment along with steroids and intravenous immunoglobulin. So I'm just giving you a perspective that HLH is not a per se standalone diagnosis. It is a manifestation, and we have to look at the various causes of HLH, consider malignancies, especially lymphomas, consider autoimmune diseases, where if you get an autoimmune disease on the basis of clinical diagnosis, then think of macrophage activation syndrome. And the third is infections, rule out viruses, rule out bacterial infections, rule out visceral leishmaniasis, tuberculosis. That's it.
Right. Thank you. Excellent, Rishi. Thank you for your inputs. Any questions at this moment?
Yes, sir. We have quite a few questions. The first question is there any critical number of significant fragmentation of RBCs per oil field? This was in reference to what is not being written.
Acha. So fragmented RBC is histiocytes in a scenario of, rather it's a scenario of microangiopathic hemolytic anemia. So I don't know why it comes in picture, but usually 1 to 2%, more than 1 or 2% is considered significant in peripheral blood in most of the adults. It should be less than 1% generally. So that's where the significance starts. But biology is not like mathematics. You need to have clinical perspective in each scenario look into. Cutoffs are just meant for assisting you. They are not meant for blocking your mind in diagnosis, right? Yeah.
And the next question is, what is the difference between emperipolysis and hemophagocytosis if it is present in lymph node, and how to differentiate?
Anywhere it is present, the two terms are totally different. Hemophagocytosis is eating up of the cell actually. And polypolysis is the traversing of cell through a tunnel. So, like you cross a tunnel in the mountain, you are still probably not soiling yourself with mud. The cells traversing through a cell forms a tunnel and is not going into touching the cytoplasmic contents. It passes through most of the megakaryocytes, and sometimes the histiocytes in some pathological scenarios will show emperipolysis. So that is how I'll put that. They are biologically different things.
And how to investigate case of severe thrombocytopenia associated with treatment with letrozole and azathioprine in case of a carcinoma breast?
Oh, sorry. Could you please?
Sir, how to investigate a case of severe thrombocytopenia
Okay.
associated with treatment with letrozole and azathioprine in a case of carcinoma breast.
So why specifically carcinoma breast? These drugs are known to cause, might cause even severe aplastic, but that's a rare sort of condition we see. Uh, Thrombocytopenia per se, if you are not associating particularly to the drug, then you will obviously look into specific causes of thrombocytopenia. Autoimmunity is one common cause. In a breast cancer where you're not suspecting a relapse or a presence of metastasis in marrow during treatment, uh, then that would be one suspicion. Okay, let Dr. Rishi come in for that question, that answer, if he can help me that.
Azathioprine is a known commonly associated with myelotoxicity. Neutropenia, thrombocytopenia happens. Often there are, if you recall some of experience with multiple choice questions, you will see that there are some gene polymorphisms that are associated with increased sensitivity to azathioprine induced myelosuppression. Having said that, in the patient also has CA breast, and my guess is that it is very likely that patient would have received cytotoxic chemotherapy some time back, alkylating agent, and now patient is developing thrombocytopenia. And if after stopping azathioprine thrombocytopenia does not recover, then I would suggest to do a bone marrow examination to rule out cytotoxic drug associated myelodysplastic neoplasm. That is another obvious differential diagnosis. But in a patient who has history of exposure to topoisomerase inhibitors, alkylating agents, these are ominous developments, and a bone marrow examination needs to be performed if the thrombocytopenia does not improve after withholding the drug.
Right, good, thank you. I will rather look into marrow with a marrow cellularity, which might be depressed in odd case, a tumor being present there. Obviously, what Dr. Ishi said, an MDS which might come into picture after some years, as rapid as 2 to 3 years, or maybe much longer than that also. MDS coming into picture, and even HLH at times, depending on scenario. So that is what we'll look into the bone marrow. But all of these conditions generally do not produce an isolated thrombocytopenia. It might sometimes present as an isolated, but usually will go into multiple cytopenias, most of these conditions. Yeah.
Less than 2% of MDS present with single lineage dysplasia and thrombocytopenia.
Right.
So, and having said that, azathioprine is not routinely used in treatment of CA breast. So there is something missing here.
Right. Thank you. Yeah. Okay. So we move to next.
Sir, there are no more questions so far.
Okay. So yeah, it's dinner time. For here, at least.
Yeah. So I think I would like to take this opportunity to thank Dr. Sachdeva and Dr. Dhawan for a wonderful presentation. I'm sure everybody learned quite a lot. Even I learned a lot of things today, and it was a wonderful slide seminar. Thank you so much.
So how many of attendees want to do DM in hematopathology?
Okay.
What a question, man. Rishi, you're asking me.
I cannot offer you DM hematopathology. So that is my question.
Out of the 6 students who have been attending, 5 students, you're asking them or the attendees also?
Attendees also. There are 128 odd people here.
Still there? Yeah, means you can see that.
If this question would have been posed to me, or if this platform would have been there, I would say 10, 12 years ago, I would be the first person to step in.
So one of my motivations is to attract good talent to our specialty. Make the residents interested in the field. There is so much to explore, and unfortunately, in our country, medical education access is not uniform in all the institutes, and Dr. Gujral's endeavor is trying to bridge the gaps and make hematopathology, in particular pathology in general, accessible quality education by specialists. So hopefully you get interested in marrows, flows, and we might have you at our institute in future. And I've many of you may not know, but I am Dr. Manupdesh's student, and this is just a trailer. It is a pleasure to see him report on the multi-header. Superb morphology reporting. Old timers would say that there was this book of pathology by Boyd, where the language was very interesting, and many people used to read Boyd just for the language. And if you see Dr. Manupdesh reporting on the multi-header, it is equally interesting. It is very interesting to see him report the morphology. So that is all Dr. Gujral's credit that we are having the opportunity to interact with and listen to Dr. Manupdesh after.
Well, thank you, Dr. Rishi. It's better we don't go into self. That's fine, right? Thank you. Right, and yeah, I believe hematopathology or DM hematopathology is you get into that direction.